Thank you very much. I was surprised when John Kellum asked me to speak, and that is the title he suggested. But then I thought about it, and I guess he understood that when this paper came out, the first seminal paper, we wrote an annals piece against it, and I gave lectures for about 10 years trying to prevent it from being instituted because the data weren't there. I have no conflicts of interest to report. And I think it's important to look at this realistically, because those who cannot remember the past are condemned to repeat it. I'm going to first give you a critical overview of early goal-directed therapy based on only facts that were known before process, arise, and promise. I think the medical journals and the review process and the academic industrial complex failed you. Then I'm going to discuss in our field the importance in clinical trials in our field of critical care of reproducibility. And then I'm going to go over a cautionary tale of how early goal-directed therapy actually got mandated by Medicare. So the following slides are from a debate, they're the actual slides that I had with Dr. Rivers on early goal-directed therapy in 2007. This is before Promise and Arise. And what we were concerned about is the following. The Surviving Sepsis Campaign and the Institute for Healthcare Improvement wanted to make this the standard of care. It had already been adopted largely by this time, 2007, in emergency rooms. And what we were particularly worried about was that in the event of hypotension, it recommended using a central venous pressure catheter and measuring an SvO2, which were commercially available to do both through Edwards. So in this lecture, my topic was, or this debate, was the evidence sufficient? Now I'm going to have to get into details because when something is so unbelievable as the result of this trial, you have to look at the details in order to figure out, is it really real? And this is from the slide that is from the original paper on early goal-directed therapy. It's the graph which shows the protocol. And if you had a blood pressure systolic less than 90 and a lactate of 4, you got either standard therapy or early goal-directed therapy or randomized. And you have to remember that both groups had the same hemodynamic goals. They both were supposed to get fluids, to maintain a CBP to 8 to 12, a blood pressure greater than 60, and a urine output of greater than 0.5 mLs per kilo. But for some reason, more standard therapy failed to attain these goals, even though they were the same goals. And there is only one, in terms of 18 versus 1, who obtained this set of goals in the paper. Why? Why would the standard therapy arm not attain the same goals if they had the same treatment goals? The other thing you must remember in this paper, it said that you were supposed to use vasodilators, nitroglycerin, if the blood pressure was greater than 90. That's correct, vasodilators. And you're supposed to give, if the SvO2 was to get reach of 70% or greater than 70%, you're supposed to transfuse to a hematocrit of 30 and dobutamine. So according to the protocol, vasodilators, dobutamine, and blood to a hematocrit of 30 is what early goal-directed therapy differed from the standard therapy group. So 90% of the patients in the standard and the early goal-directed therapy arm finished the 6-hour protocol. And this is a remarkable result, a 34% decrease in mortality with blood and dobutamine. But for some reason, the early goal-directed therapy arm got much more fluids, yet they had the same hemodynamic goals. The hemodynamic goals are the same, but the standard therapy arm got less fluid and did not meet the combined hemodynamic goals. Is that a protocol violation? Why was the standard therapy arm undertreated? The early goal-directed therapy arm also got more blood. Well, that doesn't make sense. If they got more blood, would this result in less fluid, not more than the standard therapy arm, to reach the same hemodynamic goals. And they got 13% of them got dobutamine. Now, the other thing that struck me is this is what one would expect, that if 90% of the patients were spent 6 hours in the emergency room, the mean time in the emergency room would be 8 hours plus or minus 2.1 hours, and I'll show you what I mean by that. If you figure it's normally distributed, and the mean is 8, and you subtract one standard deviation, which is 33%, that leaves 16% of the patients spent less than 6 hours. And that's what the paper said, that 10%, so that's pretty close. But now look at the standard. So this is consistent with a normal distribution for the 6 hours of time spent receiving the hemodynamic protocol in the emergency room. But now look at the standard therapy arm. 90% of the patients spent 6 hours, according to the paper, but yet the mean time in the emergency room is only 6 hours. Boy, that's really hard to understand, because 50% of the patients shouldn't have spent 6 hours in the emergency room if the mean is 6.3 and it's normally distributed. And yet the paper tells us that only 11% of the patients in the paper spent less than 6 hours in the emergency room. So data from the standard therapy group is not consistent with a normal distribution, unlike data from the early goal-directed therapy patients. If the time in the emergency room for the standard therapy group was 6.3 hours and 89 or 90% spent 6 hours, then almost all of them had to have been discharged exactly between 6 and 6.3 hours, and there had to be 3 or 4 patients that spent days in the emergency room. This data seems questionable. The standard therapy arms appears to have been treated differently than early goal-directed therapy patients and not according to protocol. So the CVP goals are the same, but yet the patients that got early goal-directed therapy got a higher CVP. The blood pressure goals are not quite the same, but the patients that got early goal-directed therapy had a mean blood pressure of 95. So remember, if your blood pressure is greater than 90, the protocol in the New England Journal says you're supposed to get vasodilators. There's no mention of any patient getting vasodilators in the New England Journal paper. So this is a slide that Rivers presented during our debate, and it's what made the difference in the SVO2. And what struck me is this. The 13.7% of patients that got dobutamine, they also got digoxin, and that was to slow the heart rate. But digoxin doesn't treat tachycardia associated with dobutamine, and the New England Journal article does not describe digoxin as part of the early goal-directed therapy protocol. So when the paper came out in 2001, we wrote a journal club in 2002 for the Annals of Internal Medicine in June 2002, and we said basically what I just told you, that during unblinded treatment in the emergency department, the same hemodynamic goals of CVP between 8 and 12 and of a blood pressure between 65 and 90 were used to trigger fluid boluses and vasopressor therapy in both groups. For some reason, the controls received less fluid, and consistent with this treatment difference, had lower CVPs, mean arterial pressures. Furthermore, 18 of the 133 patients in the control group, but only 1 out of 130 in the early goal-directed therapy, did not reach the combined physiologic endpoints for CVP, mean arterial pressure, and urine output. Because of this inconsistencies, we did not recommend early goal-directed therapy to the editor. Clearly, septic patients are best promptly treated by rapid antibacterial therapy and rapid life-saving resuscitation based on frequent physiologic measurements. So, using an SVO2 catheter to give blood and dobutamine, in-hospital mortality was decreased by 34%. Single center, unblinded, and the actual data comparing the control and treatment group were inconsistent with the set hemodynamic goals and completion of a 6-hour protocol. Previous published experience suggests that confirmatory studies in sepsis are critically important to change practice. Now let me next turn to that issue of reproducibility in our field. The question is a single significant randomized controlled trial sufficient to highly recommend and widely adopt a therapeutic intervention in sepsis. Well, I've been in the field for 35 years, and I think I've captured most of the treatments that were found to be significantly beneficial that were non-antibiotics. And I'm going to show you that data in a sort of meta-analysis. So, J5 antiserum and monoclonals against endotoxin were both papers published in the New England Journal. Now, in red, I have the beneficial trial. This was an antiserum created in firemen by injecting them with endotoxin and then giving their serum to septic patients. And this was a monoclonal antibody. And red shows the significant beneficial effect. But you can see all the subsequent trials couldn't reproduce this benefit, and the p-value is 0.59. And in terms of the monoclonal, the subsequent trials couldn't reproduce this beneficial effect, and the p-value is 0.6. High-dose corticosteroids, before 1980, there was a trial beneficial by Schumer out of Chicago. It was highly statistically significant, and even we at NIH began using high-dose steroids. But over the next 10 years, randomized controlled trials couldn't reproduce this effect, and it was actually harmful in sepsis. IL-1RA was shown in a phase 2 study to be significantly beneficial, and that couldn't be reproduced. Activated protein C, we all know, was in the New England Journal paper, randomized trial. That couldn't be reproduced. And intensive insulin, we all know the original beneficial paper, and in multiple studies, that couldn't be reproduced. And there's a highly significant shift from the beneficial significant trial to the final trial of 003. But now let's look at early goal-directed therapy. I have that now here, and this is the beneficial trial, and there were 3 subsequent trials: Process, Arise, Probus, and if we combine those 3 trials, there's a highly statistically significant p-value of 0.01 different effect. Next, an airing of the early goal-directed controversy in the lay press. Early goal-directed therapy was a front-page story in the the Wall Street Journal. And I'm going to bring you now direct quotes from the Wall Street Journal from 2008. These are direct quotes. The New England Journal article analyzed 263 patients, but it also said that 288 patients were evaluated, of whom 25 were excluded and did not consent to participate. In an April interview describing how the author did the trial proceeded, he said that all 288 are randomized. 25 patients being excluded after randomization is highly unusual. Normally, you only see 2 or 3. This is 10% of patients can change the whole result of a trial, and it's something that's very rare. It's not something commonly seen. Statisticians from the study who worked on it, that is the New England Journal paper, had concerns about the data and recalculated the results with all 288 patients. The death rate gap wasn't statistically significant. But particularly worrisome is the statisticians were concerned when they noticed the relatively high proportion of the other 25 randomized but excluded were either conventional therapy patients who survived or patients on aggressive therapy who died. In 2005, a resident doing follow-up research complained to the senior hospital officials about the data. The hospital convened a panel of inquiry which concluded the issues had been satisfactorily resolved. But most worrisome, they refused to provide that report to the reporter. Now, these are direct quotes from the Wall Street Journal concerning the unreported potential conflicts of interest. The senior author in the hospital over the years have received at least $400,000 from Edwards at the Irvine company that makes the catheter. Edwards said it paid the senior author $158,000 to make speeches about his research, $20,000 to reimburse him for patent legal fees, $36,000 in reimbursement expenses, $40,000 in consulting fees. The senior author also held the SVO2 catheter patent and transferred it to the hospital. Last, a cautionary tale about how this catheter actually became mandated by the federal government to be paid for, or use of measuring an SVO2 in a CVP became mandated by Medicare to pay for it. You really should know something about the National Quality Forum, because it's going to be important, because they're going to determine a large part of our care. It's a not-for-profit organization composed of medical societies, healthcare corporations, insurers, trade associations, and manufacturers. By law, the National Quality Forum selects performance measures for use by Medicare. That is, people submit them and they evaluate them, and then submit them to Medicare, and they can be part of accreditation or they can be pay for performance. Performance measures are processes of care designed to improve clinical outcomes. Demling started this for use in cars. The idea is if you put a whole bunch of therapies together for one disease, you think you can overall, by process of making sure they're given, improve outcome. It's used for professional accreditation. It's widespread in insurance companies all over the country and various state legislatures. And it serves for delivery as a basis of third-party payers. The National Quality Forum states that its performance measures are the gold standard for healthcare quality and undergo rigorous scientific and evidence-based reviews. So there was a severe sepsis and sepsis shock management bundle performance measure submitted to the National Quality Forum in 2008. And it was endorsed and submitted by Henry Ford Hospital, and it was entitled Severe Sepsis and Septic Shock Management Bundle. And within it, it had the monitoring of a central venous pressure and oxygen saturation, but they didn't accept that in the bundle, and they didn't approve it. It wasn't endorsed. Then in 2012, the bundle got resubmitted again, and this time they resubmitted the same part with the central venous catheter and measuring the SVO2. In the event of arterial hypotension, despite volume resuscitation or lactate of 4, measure central venous pressure and central venous oxygen saturation. And it was submitted again by Dr. Rivers. And in 2013, in contrast to 2008, when they refused to endorse the CVP and the SVO2, the National Quality Forum this time endorsed the full sepsis performance measure, including its requirement for central venous pressure and oxygen measures. And this occurred despite objections from multiple professional societies. Multiple societies wrote letters, and there was no new data from 2008 to 2013 showing that this measure worked. And at the time that they endorsed this bundle, there were 3 ongoing multi-center clinical trials testing this use of CVP and SVO2. As these trials were going on, they still approved this. The 2012 application included 4 sources of evidence: the Surviving Sepsis Campaign Guidelines, a retrospective analysis from approximately 15,000 patients, 55 individual studies, and 3 meta-analyses. And let me go over this with you. The Surviving Sepsis Guideline gave the evidence supporting central venous pressure and oxygen saturating measures, and their actually own guideline a very weak grade, C. Yet, inexplicably, they gave the measure a high grade and recommended it for use. The retrospective analysis of 15,000 patients was based on uncontrolled data from unrefereed sites and could not account for confounding variables. Of the 55 studies cited, 31% of them didn't even have a control, 38 studies providing comparative data only. There was 1 RCT, which we've already discussed already, that there was been cited for lapses in data integrity. The other 3 RCTs were performed in China, where the patient mix and medical practice differ markedly from Western countries. There were 3 meta-analyses cited. One concluded, that is our meta-analysis, that the studies provided no convincing evidence to support the sepsis bundle. Another meta-analysis examined 21 studies, but 20 were observational. The only RCT compared early goalie components, but had no controls. 3 meta-analyses included studies which the treatments were greater than 6 hours, and they included non-septic patients. So how did this happen? Well, there were potential conflicts of interest. Edward Life Sciences, a manufacturer of the SVO2 catheter, stood to profit directly from the sepsis performance measure's full endorsement. Since 2008, Edwards' chief executive officer has served as chairman and then member of the board of directors of AdvaMed, a medical trade association. AdvaMed nominated its vice president to the National Quality Forum Steering Committee reviewing the sepsis performance measure. This vice president was actually co-chair of that steering committee in 2013, a very influential position. Once Edwards' CAO was elected to the AdvaMed's board of directors, the National Equality Forum should not have accepted the trade association's recommendations for steering committee membership evaluating the sepsis performance measure. Shortly after publication of the first of these three non-confirmatory trials, the National Equality Forum removed the requirement for CVP and SVO2 measures and CMS, and then delayed implementation of the sepsis performance measure. So, early goal-directed therapy represents a failure of the academic, medical, industrial complex to evaluate and institute a new therapy. Non-reproducible science cannot teach us how to care for patients. To learn from this experience, prominent medical journals, medical societies, guideline committees, and CEOs of hospitals should examine why they endorse these practices for septic patients, and the National Quality Forum included them as performance measures required by the Centers for Medicare and Medicaid. Thank you for your attention.